proper study comparing conservative treatment versus operative treatment. Kukkonen from Finland, Moosmeijer from Norway, Heerspring from the Netherlands. And interestingly, there were 2 systematic reviews done on these exactly the same studies. A Finnish meta-analysis and an American meta-analysis. And it is so interesting if you look to their conclusion. The Finnish guy, they found out, scrutinizing these 3 studies, surgery is not more effective in treating rotator cuff tears compared to conservative treatment alone. So a conservative approach is advocated. But look to the Americans. They look in a totally different way to the results of these 3 studies. They think there is a statistically significant advantage in both objective and subjective outcomes with surgery. And the next sentence is very strange following this previous sentence. This statistical advantage is not a clinically significant one. That is the most absurd sentence I've ever read in the conclusion. The most remarkable finding of this study is the paucity of high-level evidence available to guide for rotator cuff tears. So you see that from 3 the same studies, some people say you should stay conservative, and we Europeans generally are rather conservative, especially the more northern part of Europe is more conservative than the south part of Europe, quite interestingly. But the Americans generally are quite aggressive, and they conclude that it is an advantage to do operation. Isn't it striking? I show one case I did. A male, 62 years old. He had a fall in 2014, no dislocation, no previous symptoms, and he's only mild painful. I didn't see the patient that time. There was an MRI made, which was shown to me. He has a curvature, as you see here. A rather good supraspinatus, mild atrophy. There's a tear of the supra and part of the infraspinatus. Well, I wouldn't make it too long to do a questionnaire, but he was mild painful, so he did not have any specific treatment. 1 year later, there was a new fall with a shoulder dislocation. It was reduced in the hospital. He was shown to me. You see here, supraspinatus, a little bit more atrophy, a little bit of fatty infiltration, and clear, a little bit high riding. So the supra and part of the infraspinatus are involved. And it is the MRI of the bone defect due to the dislocation, the glenoid fracture. So quickly go through this question. I operated on him. I think challenging to do the cuff repair. You're still there, so you repair it. And I did a bony banklet repair. 1 year follow-up, no pain, full range of motion, stable. He was very happy. I was happy too. But then out of curiosity, I made an MRI. My cuff failed. So I did a useless operation. It was a rather good operation. I was quite happy with it as a result, but it failed. And it was the bone healed. So basically 3 questions. A cuff tear is actually a sign of normal aging. We should question if the tear is always the cause of the pain. And why is surgery successful clinically, although 50% is failing? So I think there are many arguments to remain conservative before jumping to surgery. Thank you.
Thank you, Jaap. So the issue is we have to take a call that tomorrow when I see a patient of rotator cuff tear, how should my mind work towards treating it conservative or not conservative? Though COVID is in the background, but COVID is going to be there maybe for a year or 2 years or maybe 3 years at the most. But we cannot hide behind COVID and give a patient disability for the rest of his life as well. So we have to choose based on the risk and the benefit involved. So can I ask you, Jaap, tomorrow morning or say in the background of COVID, if I have a patient, let's talk about younger patients who have long life to go where disability is important. So if we have a young patient, usually trauma-oriented, let's say about 1.5 centimeter or say 3.5 centimeter tear, traumatic. Would you consider conservative treatment in these patients? Or with or without COVID, would you consider operative?
Yeah.
The 50-year-old active guy, two scenario, 1.5 centimeter and 3 centimeter.
Yeah. Well, I think that is the most important question. You're talking about a little bit different animal, the traumatic tear in a young patient. A 45, 50-year-old, he has a traumatic tear. That is a little bit different group of the group we normally see with the degenerated tear. I would opt in that patient for surgery after proper conservative treatment earlier than the majority of the patients who present in our clinic over 60, 65 with a degenerative tear and pain. In the last group, I would definitely go in this period full time for a longer period than normally for conservative treatment, try to rebalance the shoulder without pain. But that animal, that patient visiting you tomorrow morning, I think it is like a trauma. And in trauma cases, we operate. So I would advocate. And for that reason, I would like to show one slide. The Moosmeyer study, he found, Moosmeyer did one of these proper RCTs. He had 2 and 5 year results. He published in JBS. There was no difference in conservative and surgery. But at 10 years, and it is actually the only study, proper RCT, 10 years follow-up, a supraspinatus tear repaired surgically is doing better than conservative. So there is a plea, and I think for younger patients, there is a plea to consider surgery. But in this COVID time, it makes sense to stay a little bit longer conservative, but still consider surgery in that small subgroup of patients.
So can I conclude that younger patients traumatic are still like trauma, nothing changes with or without COVID, yes. But and on the other extreme, the older patients 70, 75 plus, whether in the past or in the future, you would be conservative. The important is the gray zone in between, where we till yesterday used to consider surgery as the first option sometime, or we were kind of little bit quick about surgery. In those cases also, we will now, pendulum will shift towards a conservative now before we consider surgery for them. That means the gray zone where we were doubtful, in future we would rather be conservative in them, because it's not a great deal of result difference as well as quality of life difference. Any other panelist wants to make any comment?
So, Dr. Maheshwari, can I say a couple of things?
Yeah.
So, couple of things. In the NHS in UK, we have this advantage of a waiting list. So we can't operate on many people for about 4 or 5 months sometimes, and after COVID, it will be 6 months, 7 months. And so all my patients, not the young traumatic one as you were talking about, the one with degenerative tears in say about 60 years of age, they all go, they wait for surgery, and hence they all go for non-operative measures. So, but we put them on the waiting list for surgery. And almost 20% of these patients, they drop out when their turn comes for surgery, because they have got significantly better waiting and doing their exercises. So it is very difficult to choose which ones will do good and which ones will not do so good. So that's why we put all of them for physiotherapy first for 2 to 3 months. If they are getting better, we'll persist with physiotherapy. If they're not getting better, you put them towards surgery. That's what I do here. The second point I wanted to ask Yap is, the 2 comparative studies, one was from Scandinavia, another one was for US. Do you think the interpretation or their conclusions were different because the way they are paid for their services?
Yes.
This is a question for Yap, please.
Yeah, I think it is partly payment, definitely, but also definitely culture. What I have seen happening in the United States, that normally they are more aggressive in everything. In the periods when we started to consider ACL surgery, and still are conservative. Americans generally, I'm generalizing, I should realize that, they operate on every torn ACL. If they treat patients with antibiotics, normally it is the double dose what we normally use. So there is generally a cultural difference in treatment and partly payment, but it is definitely, to be honest, if I operate on the rotator cuff in the Netherlands, I get better paid than doing conservative treatment. So it is partly payment, but definitely cultural differences.
Yeah,
Sanjay,
yeah.
okay, Vivek and Sanjay, you should tell me where are we as far as culture is concerned, European or American?
We choose to side whenever it is benefiting us most of the time. If patient is reasonably fit and if finances are good, we offer them surgical. If patient has financial issue, some medical issue, then we always shift them towards the conservative. But issue when you operate the young patient in this COVID situation, would the panelists prefer arthroscopic surgery under general anesthesia or some regional block and mini open repair, Dr. Maheshwari? That is the also a pertinent question.
So, yep, you have, or anybody would like to answer this? Yep. Whether COVID situation should change your decision to do mini open versus arthroscopic, considering the risk of surgery, maybe more in
Or
arthroscopic.
anesthesia, general anesthesia, closer to the face, intubation has issue.
Would that make any difference whether you do it arthroscopic or open?
Yeah, well, of course, there are several issues regarding this choice. Arthroscopic is definitely more expensive with all the elements you need compared to mini open. To be honest, if you do a regional block in a COVID patient, you should be as careful as with intubation. I don't see much difference in this choice. But especially when you're talking about the choice that budget of the patient, if he is not able to pay, you treat for conservative. That is, although quite understandable, not very fair. Each patient should need the treatment, he should get the treatment he needs. And there are, of course, this sort of issues, but it is a little bit, I think, not fair to the patient. You should choose because of medical reasons, technical reasons. And if you think a young patient needs surgery, even if he is poor, then it is very pity, but he still needs surgery.
Vivek, your practice of open versus arthroscopic. Can I just ask Vivek? Would your practice of open versus arthroscopic change because of COVID?
I'll ask one question from Yap and then I'll come back to you, sir.
Okay.
Yap, regarding your, the take on the conservative versus operative. So we were kind of generally concluding that traumatic tears take some precedence over, over the years, the degenerative tear. Now, what is your take on a traumatic tear in a otherwise normal shoulder in a older patient? And when I say older, let's say 65, closing to 70, who says my shoulder was absolutely normal. He's 70 and he says my shoulder was normal. And let's say he's on your follow-up. You have done his old some MRI of shoulder or, the neck, and he had a fall. And now he has come with a pseudo paralysis, not a small tear in supraspinatus, which you can manage conservatively. So what is your take on massive tears or 1 or 2 tendon tears with a pseudo paralysis, which is traumatic in nature? Should we operate or should we manage them conservatively?
Well, I like the division Ram made before BC and AC. BC, I definitely would advise surgery because it's very helpful also in the 70-75.
No, yeah. Let's keep it to the principles. Okay, let's not bring UC, BC because someday, the AC will become again, okay, AC normalized. So it's okay. We will take the principle first.
Yeah, the principle is that you should give very proper physiotherapy. Some of them do well, some of them don't. You can go and wait up to 6 months in a traumatic tear before deterioration, and then still do surgery. And
Okay.
still, I would involve the COVID time. I would go for a longer period because
Of
the
course.
70-year-old is a higher risk patient for the COVID.
Yes, yes. Okay. All right.
Just one comment about that whether to do arthroscopic or open. As far as the COVID risk is concerned, it is only the anesthesia. Sorry, am I got it? Is it only the anesthetic risk by operating close to the shoulder? So is it going to be any difference between doing arthroscopic or open? The question is what time you take it. Is that right? Whether the time of your operation, whether to do, you're doing a long arthroscopic and you can do a quick, say, mini open, that might be preferable because you're reducing the exposure of the time. Otherwise, it might not make any big difference.
Sanjay, it is said that actually giving GA is safer because you intubate the patient. So only for the time of intubation and extubation, there is a risk. After that, there is no risk.
Yes.
Actually, that way, there is a contradictory opinion that probably if patient is fit, otherwise, there's no GA risk. Actually, giving GA in a COVID patient is actually safer.
But sir, contamination, risk to the anesthetist, and the overall increase in the cost in a private or corporate setup, in that context, I was discussing all this.
Dr. Pandey, you want to say something?
Yeah, I quite agree with you, Dr. Maheshwari, that whether to go for GA or regional. So what we do is we anesthetize the patient under the laminar flow. And after the intubation, all the surgical team waits outside in the scrub room. And then we allow 5-10 minutes for the air to circulate. That way it cleans up the thing. And then we go and start surgery. And you are absolutely right. The risk is only when you are intubating and extubating. Otherwise, the air breathing out of the patient's body is being channeled through a tube. Whereas if the patient is awake, he's constantly breathing. He can cough. He can, and you are quite close to his face. So despite the fact that there might be a barrier, the risk is slightly higher because the patient can cough, sneeze, or even talk and breathe.
Okay.
So
Ram,
that can be problem.
may I interrupt? Ram, are there any questions from the audience?
Yeah, there's one comment from Ashish. He's just going to join shortly. And we have to worry about the real risk of at least 20% risk of mortality and surgery with COVID. And so unless if it's an emergency or pseudoparalysis, one should not operate at this time. So just the timing of operation, we have to stay back.
So can I make a comment on this? I think to decide more towards non-operative treatment as a trial, because it's not a life-saving surgery, is okay. But if you operate, I think you have to do the best possible, COVID or no COVID, yes. GA or no GA, doesn't matter. Once you take the patient to the operation theater, you have to do exactly what is best in your hands. No compromise at all. You can compromise at not doing it because you want to give it a trial of conservative, which is okay. Because you lose nothing by operating after a 2-3 months period. That's okay.
Okay, you can move on. I think we are trying to get Abhikar signing in. I think I just made it, I updated the software and put it more secure. So unless the person has registered before, it's not allowing him to come and join. Can we request Radhakant Pandit to give the talk? I will arrange Abhik to join.
Yeah, that's okay.
I don't think he's still here. Okay.
Maybe Dr. Pandey can share his screen.
Yes, please.
Yeah, you have to stop sharing your screen.
Yes.
While Dr. Pandey is sharing, Prophet trial had already churned the fracture humerus word already before even COVID. I'm sure it is going to do it more now.
Okay, can you see?
Yeah.
Yes. Really?
Can you see the slide?
Yes, we can see the screen.
Yeah, okay. So let's talk about non-operative management of proximal humeral fractures. it's a talk we do in our Leicester shoulder course. So it's part of it is taken from there. So there is a trend. When I was growing up as a shoulder surgeon, we used to operate on roughly 10 to 15% of all the proximal humeral fractures. Now I think we are doing significantly more. If I show you this X-ray, I mean, yes, you can criticize any X-ray, but I would say this is a reasonably well-fixed proximal humeral fractures. Would you agree? And the fracture has now healed. So one would expect very good result from this fixation. Now, this is the lady who's had the fixation, and you can see she's only got about 90 degrees of forward elevation and very little external rotation, almost 8 months down the road. So just because you improve the X-ray and fix it doesn't necessarily mean your shoulder will give you better function, because shoulder is a very different joint. It has got a lot of soft tissue component to it. Now, in contrast, this is another case where you can see the tuberosity is gone significantly higher. And we've had a discussion with the patient, and for some reason or the other, we continue to treat this non-operatively. Now, this has gone on to heal, and this is what the result is of the patient. He is in his late 60s, and he can do almost anything, including playing golf. And I think, had I operated and fixed that fracture, I probably would have given him just about this result. This is an 80 years lady. This is one of my colleagues, Mr. Harvinder Singh's, who's also participating. And you look at that, and the tuberosity is almost flipped 180 degrees. This lady had some comorbidities, so a lot of humming and hawing went on, and then eventually we decided to treat this non-operatively. I mean, you will shudder if you see this X-ray and say, okay, I'm going to treat this non-operatively. But so we even saw the improvement in tuberosity position. Eventually, this thing healed in this position. This lady is able to drink her tea and is able to eat her food. She's pain-free, and she's able to do all the basic functions of life. And she's quite happy. So I don't know if I had done a fixation or a hemiarthroplasty, I would have got any better results. And I'm not so sure whether a reverse shoulder would have done significantly better. Again, another case, a displaced fracture, which patient was initially put on my list for surgery. I had a talk with the patient, and then this fracture eventually started to heal. And this is the lady, she's delighted with her shoulder. So beware. Surgical treatment, mainly internal fixation or humeral head replacement, is being increasingly used, increasing treatment costs for shoulder fractures. And there is a Cochrane review found insufficient evidence from randomized clinical trials to conclude whether surgery produces consistently better outcomes than non-surgical treatment. So just because you've done surgery doesn't necessarily mean that you'll get a better outcome. And for displaced fractures, surgery may not always result in a good outcome. In fact, many times it can result in disasters. And all of us have seen or have a collection of X-rays like this, completely fallen apart, something penetration, and arthritis, failure of fixation, bad fixation, avascular necrosis, and then you have to remove a lot of metal work, which can be very, very difficult. So surgery, and also once you start doing proximal humeral fractures, you need to be good at not only percutaneous, you have to be good at plating, you have to be good at nailing, you have to be good at hemiarthroplasty, reverse shoulder arthroplasty. So it's a pretty difficult operation, and it's not for the occasional shoulder surgeon. Trauma for shoulder surgery is much more difficult than doing a cuff repair or even arthritis surgery. So trauma is difficult surgery. I am not saying that you don't operate at all. There are certain conditions where you be forced to operate to give a better result. Like here you see the tuberosity is completely off. One could argue that tuberosity is off in a young patient. I want to fix it. Fracture dislocations like that, or very, very displaced fracture in a very functional shoulder. Yes, you can still operate. But what I am objecting is the increasing trend, which has been growing pretty fast with more number of surgeries being done. Now, these are all the cases which were initially listed for surgery. All of these were treated non-operatively with pretty good functional results. And that is my main focus, is to step back, think, just because the position doesn't look perfect, doesn't necessarily mean that the patient will be at a disadvantage in later years. As Dr. Maheshwari keeps talking about his acceptable malunion, I think a shoulder surgery, shoulder is a pretty good joint which compensates for a lot of malunion, and you have to decide which malunion will be acceptable, which malunion will not be acceptable, and that takes a bit of gray hairs and some experience. This is another case which somebody wanted to operate, and I said no, don't. And this is one of my happiest patients ever. And he even sends me bottles of whiskey once in a while because he escaped surgery. One has to balance what the patient wants with what you want to give. And this patient is very happy because she can drive a car, drink a tea, and do normal function. This tuberosity is a bit higher, but so what? She's fine. So this is the PROFA trial, and I know it's a busy slide, but there's nothing, it's not a very complicated slide. It's a randomized controlled trial in which if you saw an X-ray and you were